Wonderful. Good morning, everyone. I want to welcome you all to the reemergence of the UCSF Department of Psychiatry and Behavioral Sciences Distinguished Visiting Lecture Series. So as you all know, for at least the next year and a half, all of our lectures will be from outstanding women leaders in our field, and no one more so than today's speaker, Dr. Patrice Harris. Dr. Harris is the immediate past president of the American Medical Association. As the 174th president of the AMA, she was the organization's first African-American woman to hold this position, something that I think deserves all our reflection. In addition to guiding the organization through the extraordinary challenges of the first phases of the COVID pandemic, as president, she advanced several overarching goals that have really defined her career. This includes championing the integration of public health, mental health, and physical health, increasing the diversity of the workforce in the service of equity, and addressing childhood trauma. A bit of background: Dr. Harris completed her undergraduate degree in psychology and a master's in counseling psychology, and then an MD from West Virginia University. She then went on to Emory, where she did a psychiatry residency and then fellowships both in child and adolescent psychiatry and in forensic psychiatry. Currently, she's an adjunct assistant professor in the Emory Department of Psychiatry and Behavioral Sciences and an adjunct clinical assistant professor in psychiatry and behavioral sciences at Morehouse School of Medicine. Now, Dr. Harris remains extremely active in the AMA. She's spearheading their efforts to end the opioid epidemic. She's been chair of the AMA Opioid Task Force since its inception in 2014. They have been working diligently across every state to eliminate barriers to treatment, provide all patients with access to affordable non-opioid pain care, and to fight the stigma faced by those with substance use disorders. She's a distinguished fellow of the American Psychiatric Association, and she continues now in a private practice consulting with both public and private organizations on health service delivery and emerging trends in practice and health policy. So I had the great pleasure of meeting Dr. Harris just before she started her year as president of the AMA at a reception that we co-sponsored with the San Francisco Marin Medical Society. And I've been looking forward since then to her coming back to spend more time with us. I'm sorry that this has to be by Zoom, but I want to thank you again, Dr. Harris, for agreeing to do this lecture and to move us back towards something resembling academic normalcy. Today, we're going to hear about a profoundly timely and important topic: physician leadership in creating a more equitable healthcare future. At the end, just a bit of housekeeping. We're going to leave 10 to 15 minutes for question and answer, and Lisa Fortuna, our Vice Chair and Chief Ed Zuckerberg San Francisco General, has graciously agreed to moderate. So Dr. Harris, welcome, and thank you so much for joining us today.
Well, thank you so much for having me, and I'm glad you were recalling our time together last year, because that was a great couple of days for me, and I'm so glad to have this opportunity, albeit virtually. And what an honor for me to be the first in your return to these lectures. I have had a career of first. And as I have said on so many occasions, the wonderful opportunity to be the first is to make sure you're not the last. And so again, what an opportunity for me to be with you today. I want to, first of all, say that we are going through a tough time on so many levels, and we are seeing so many people finally, present company excluded, attend to mental health. Truly, this pandemic has brought into stark reality so many issues. I'll be talking about equity, but of course, conversations around equity have to occur with conversations around mental health. And so it was a great opportunity for me to elevate those three things that I talked about in my inaugural address. And clearly, of course, no one wish COVID on this world, but I said I wanted to elevate the importance of integration of mental health into overall health care. Wanted to talk about increasing the diversity of the physician workforce, but not as a checkbox, but really in the service of moving us toward a more equitable future, and particularly healthcare. And third, the importance of childhood trauma, but clearly we have had to have conversations around trauma in general as we are navigating through this current pandemic. So I hope today to hit on all of those topics a little bit further, and I look forward to the question and answer period. So I'll ask my team to bring up my slides. And I do think that a physician leadership is required if we want to create a more equitable healthcare future. I think there been some dialogue, debate, difference of opinion. All of those are okay as long as it's fair-minded about physicians' role in this work, in, if you will, the work outside of our exam rooms. And, we would argue at the AMA that it really is written into our code of ethics. But also, we have a front row seat, physicians and other healthcare professionals, we have a front row seat to the impact of all of the determinants of health. And I would argue who better to talk about these things than us, physicians, healthcare professionals. Now, and as I'll mention a little later, it is certainly not our responsibility alone to take care of these problems. It takes an all-in approach to do so. Now, I have this slide. You've already heard about my journey, a little bit about my journey and my bio. But I've kept this slide in because I want everyone who's listening to my voice to take a minute, and hopefully you do this every day, to think about you. Again, it has been a tough time for all of us, and we are in the helping profession and the helping business, oftentimes, of course, helping others, and we don't always take a moment to make sure we are okay. And so I try to do this every morning. I'm not saying I'm perfect at this, but this is an opportunity to pause and just remind us all that we do have to make sure that we are attending to our own needs. In fact, I just received an email. I think I was on CNN on this past Saturday talking about World Mental Health Day, and a part of the conversation has been around burnout of caregivers and physicians and nurses and all of us who are taking care of others. We have seen over the last several years increase in the number of suicides, and so it is critical that we take a moment to make sure we are caring for ourselves, but not just caring for ourselves on an individual level. Those of us who are system leaders or leaders in organizations need to make sure that we are elevating these conversations and that our systems are responsive and incentivize help seeking. And of course, we know in this room, particularly help seeking when it comes to mental health care. And we all know that there's still significant stigma around that, which is amplified in the physician community, which I know most about, but I think amplified in all of us who are providing care for others. But again, we have to demonstrate leadership if we want to create a more equitable future. And clearly, COVID-19 has just amplified the importance of being leaders on this issue. And so for us at the AMA, our response to COVID-19 was in three broad buckets. The first was to make sure that we were a trusted source of evidence-based information. I don't need to tell you all how much misinformation and disinformation is out there, and unfortunately it's still out there, and unfortunately there's social media, and we know that trust in institutions have been eroding really over the past several decades. But as I said actually in my address, about a year ago when the AMA was in San Diego, surveys still show that physicians still trust, patients still trust their physicians. And so what a wonderful opportunity for us to make sure individually, as institutions, UCSF, AMA, that we are seeing and out front as providing trustworthy information and as trustworthy sources. Of course, now in order to gain trust, you have to earn it. And we can chat about the activities and actions needed to earn trust. But clearly, physicians are still trusted, and there's an opportunity for us to provide information. We also wanted to make sure that physicians and practices and institutions, large and small, were able to navigate through and recover from the disruption caused by COVID-19. I'm sure you all can tell me stories of just chatting about, you all were 3% telehealth, and now you are nearly 100. Of course, I know you have a big system there and different payer mix at different pieces of your system, but clearly it was disruptive. And again, we needed to originally shelter in place, and you guys were sort of early on a hotspot location and had to act big. And by the way, you did, and your leadership, your mayor did, and that was appropriate. You acted quickly, she acted quickly, you all acted quickly. And of course, we do need to make sure that we can all recover from this disruption. And that was a huge issue on the priority list of us at the AMA. And then, as always, there are a lot of obstacles to our providing care before COVID and a lot of obstacles caused by COVID. And so we worked really hard to reduce those obstacles. I hope you all have seen our Mask Up campaign, because clearly this is an all hands on deck moment, and we are still in the midst of the epidemic. It is not going away, and while some areas have lower spread and lower transmission, we are seeing now in the rural areas increased spread and transmission. And sometimes people believe that interventions need to be complicated and high tech. But I think we've seen that in this incidence, those basic public health measures work. And so at the AMA, we've been trying to get the word out, and I'm sure you all have too, regarding those basic public health measures. Again, keeping science at the forefront. I have had the wonderful opportunity to make sure that we were out in front in the media. And I did many TV programs, radio programs, making sure that we called on elected officials to affirm science, evidence, and the facts in all of their words and actions. And some, of course, already knew that. Some heeded that call. Others have not, but it still remains our responsibility to make sure that we are continuing to send that message. Again, another issue that was brought into stark reality by COVID-19 was the unequal impact of COVID-19. We know, we saw from early data, even though it was incomplete data, and by the way, we still don't have complete data, but when we saw early on from data from Milwaukee and Chicago and DC, that Black and brown communities were being hit very hard. And this has held true throughout the pandemic. And again, not new to many, but the pandemic certainly did highlight long-standing health inequities for communities of color. And that's why the AMA early on urged CDC and HHS to not only collect the data around race and ethnicity in a standardized format so we can really have fair-minded debates about the data and really target interventions. And by the way, not just race and ethnicity, of course, gender, of course, age, those were collected usually in a standardized manner, but zip code so that we could quickly target interventions based on zip code. And again, we have seen an improvement in that, but we are still not where we need to be around collecting this data. And while I'm talking about COVID, we also know that we are at the beginning of the flu season, and the AMA and the CDC and the Ad Council just launched a flu campaign, flu vaccine campaign. And I didn't know this, maybe many of you in the room knew this, but CDC looked at data over the last 10 years, and people from Black and brown communities were hospitalized in greater numbers due to the flu. So again, not new information around disproportionate burden on Black and brown communities, but we've certainly seen it amplified with COVID. We all know the importance of the vaccine trials that are going on, but clinical trials in general, and I know there at UCSF do a lot of clinical trials, and we need to make sure that we have diverse trial groups in, of course, regarding the vaccine, but all clinical trials. And so this is a message that we have been amplifying again throughout COVID-19, because speaking about the flu and some data regarding the flu vaccine, there's a lot of hesitancy, I don't need to tell you, around vaccines. That's been amplified or increased, unfortunately, because we have decided to make a public health crisis political, and that's certainly unfortunate, but there are consequences of that. And again, we already had vaccine hesitancy. Of course, we already have had vaccine misinformation campaigns going on, and so we need to do all that we can to make sure that we are getting more and more folks into these trial groups. But again, it is not enough just to say, hey, why don't you come and participate in this trial? We have to respect a history here. We have to respect the impact of Tuskegee. We have to respect the impact of Henrietta Lacks and those stories. We have to respect the impact of operating on Black women who were enslaved without anesthesia. So we have to make sure we appreciate that information and that history as we are meeting people where they are and encouraging them and making sure they get accurate information around clinical trials. I like this framework, and this is particularly appropriate that I will say that I am at UCSF. But I like this framework from the Bay Area, and I show this slide really in all of my presentations because I think it really shows and demonstrates all of the determinants of health. I also particularly like to show this slide in non-medical audiences because I think that a lot of folks who aren't, the usual suspects, we would say, in healthcare don't see their role in determining health outcomes. And so I think with this slide, you can see all of the determinants of health, and hopefully everyone can decide or will decide to look at what they are doing, not only to create health, but perhaps to detract from health. And that goes from structural racism, long-standing policies such as redlining, all of the living issues around living conditions and whether you live in a food desert or not, all create or have the opportunity to create health. And certainly there are opportunities to intervene upstream, midstream, and downstream. And that goes again from looking at policies and looking at safe neighborhoods. Are equitable and good paying jobs available? What is the quality of education in the community? I know that you all in San Francisco deal with housing a lot, and I know you have a significant homeless population. How are we all working together to address those needs, as well as, of course, those downstream needs, and are we looking at our incarceration policies and the laws? And again, all of these are not physicians and healthcare professionals alone to solve, but we have to see ourselves as part of the solution. And I am working here in Atlanta with the group that is looking at this. And of course, we are making sure that we are centering equity, just as we are, and you'll hear a little bit about this in just a moment, about the work of the AMA to center equity, but we all need to make sure that equity is centered in all of our work and that we meet people where they are. I talk about, and others have talked about, a no wrong doors approach. But wherever you come in the door, we assess your needs. We do the screening. There's screening for mental health issues. In fact, just today, if you have not seen it yet, I know it's early in your neck of the woods, but there's a press release that just came out today about the work that the AMA is leading, along with ACAP and APA and ACOG and ACP and AAFP, on integration of mental health. And so as we do integrate mental health and as we do center equity, we need to make sure that no matter where someone enters the door or receives their care, we are thinking about mental health and we are thinking about equity, and we are working to make sure that care is coordinated. And so I really like this slide, though, because in Atlanta and with this group that I'm working with, we talk about the need to invert the burden. I don't know about you, but as a physician, I sometimes find it difficult to navigate the health systems that I have to encounter, and I'm a physician. And can you imagine if you don't have the privilege or you don't have the knowledge that most of us in this room have, how difficult it is? And so we have to make the right thing to do, the easy thing to do, and invert the burden of navigating the health system away from individuals and on to us in the system. It's been a difficult moment with COVID, but other issues are still relevant and impact health. And certainly the AMA spoke out on police brutality, certainly recognizing that physical, and this is actually policy that the AMA had prior to issues that we've seen recently regarding George Floyd and Breonna Taylor. But certainly we wanted to make sure that we elevated police brutality as a matter of public health. And hopefully you saw the statement that was authored by me and Jesse Ehrenfeld, who was chair at the time, around police brutality. And we have to have conversations around police brutality. And here, we see and must have a lot of conversations around trust. We have to make sure, I'm sorry, not trust, trauma. Trust is a piece of it, but trauma. And I did a lot of media appearances around understanding that you don't have to be directly impacted by trauma in order for trauma to impact or have an impact on you. And I'll just share a personal story that around the time of George Floyd, and here in Georgia, we had the murder of Mr. Arbery, not by police, but by other folks in the community. And I felt overwhelmed as a Black woman. I felt overwhelmed. And I sent an email to the AMA leadership, and I just said, you know what? I'm not okay. And I'm a physician, and I'm the president of the AMA, and I have privilege, and I can go to the grocery store, and I have a vehicle, but I am stressed, and I am not okay. And so you can imagine those with less privilege. And so let's make sure we are having those conversations. And I will say it was difficult, and I'm sure it was difficult for everyone, but let me just tell you, it was more difficult for me, and a lot of my African American physician friends, particularly moms, couldn't even watch the video of Mr. Floyd. It was just too traumatizing. I'm not a mother, but those moms were just thinking about their own children and their worry. So I think, again, we have to make sure we have those conversations about trauma, and both those who are directly, impact, but vicarious trauma that we all know about in this room. Another issue that we cannot forget about is chronic disease. Half of American adults have one or more chronic conditions. It takes a toll, takes a human toll, but it also costs our country and our economy a lot of money. And again, these heart disease, stroke, diabetes among the top 10 leading cause of death and disability, again, disproportionately impacting communities of color. You heard me talk earlier about my amplification of childhood trauma during my presidency. We all know the data around the ACEs study. And so now I think what we should be thinking about and talking about and doing is, what are we going to do about this? We have this data that was a seminal study from CDC and Kaiser, but what are we going to do about it? What services are we going to put in place? How are we going to understand this and make sure that all of those folks in that first slide, right, have ownership in dealing with these adverse childhood experiences? You all know I'm a child psychiatrist, and I believe strongly in the importance of early childhood education and making sure we are teaching skills around socio-emotional development and learning. And of course, again, issues raised around understanding trauma. And for those of us in this room, again, this is not new information to us, but I can tell you that in some non-medical audiences that I've been in, they are surprised to learn that childhood trauma can adversely impact cardiovascular health. And so this is health. And so this is a very important issue that we need to begin to put into practice some services and supports and resources. And of course, we all know that our mental health infrastructure has been woefully underfunded and under-resourced over decades. Of course, understanding children's mental health is critical. No real difference in prevalence, but certainly a difference in access. And so how are we going to work to solve that problem? And I'd be interested to hear your thinking about telehealth. And clearly, of course, this is something that some of us have been doing for a while regarding children's mental health. I did in my private practice here in Atlanta. Although I do, and I say this a lot, just like no other intervention, there's not a magic wand, there's not a panacea. And so I have never said that, oh, telehealth will solve all of our problems. I can tell you that some of my patients like it, others do not. I can tell you, and of course the technology will improve, but a lot of folks don't know that psychiatrists are looking at other things. I know when I go to meet my patients in the waiting room, one of the reasons I do that is because as I walk back with them, I'm watching their gait, right? And when I sit down with them in a room, I'm looking at their thyroid. We're doing all the things that, we should be doing as observant physicians and other mental health professionals, and appreciating mental health in the context of overall health. But clearly, I believe that telehealth and technology can help us decrease these issues around access to care. But we need to think broadly about that, and how are we going to address the inequities that we see, particularly with the rate of suicide increasing, again, among all youth, but particularly African American youth. Again, most people are talking, this is a good thing, about the impact of COVID on children's mental health. Clearly, lives have been disrupted, and children's lives have been disrupted. They have not been in school. They've missed birthdays. They've missed graduations. They've missed time with grandparents. And so we need to make sure, as I have said, that we keep an eye on the children. And as you know, many times those supports that are able to be early identifiers of abuse and neglect and mental health needs of children, we don't see right now because they are not in school. And so again, we need to continue to elevate this and make sure that we are working in our communities about supports for children. And I am a child psychiatrist, so I might be a little bit biased. As you saw earlier, I mentioned that Jesse Ehrenfeld and I made a statement around police brutality at the beginning of our AMA meeting in June. We had a virtual meeting. The AMA board also pledged action on racism, recognizing that racism is an urgent threat to public health. And I encourage everyone to go to the APHA, the American Public Health Association website, because I realize these are difficult conversations. They can sometimes be uncomfortable conversations. And by the way, talking about leadership, and particularly around psychiatric leadership, here is one area where, of course, we excel, in my opinion, because of our training. Typically, psychiatrists and other mental health professionals are comfortable having uncomfortable conversations. So I think we can certainly provide leadership and perhaps coach even our peers on how to have these uncomfortable conversations. But I do think that when we are talking about racism or any other issue, that we at least start with an agreed upon definition. And I won't read the full definition here, but I like the APHA definition of racism so that we can, again, move from that definition and have further conversation about racism. And of course, there's structural racism, there's interpersonal racism, there's implicit bias, unconscious bias, all of these terms. I know at the AMA we are leading on, and you can see here with our newly established AMA Center for Health Equity, and we have our new, she's not new anymore, I probably need to say that, our Chief Health Equity Officer, Dr. Aletha Maybank. And by the way, at the AMA, we are looking internally as well as externally. And this is what I recommend. And I know, by the way, UCSF has been a leader on this. Dr. Jack Resnick, who I've known for many years, and he's in the dermatology there at UCSF. But we talk about the need, and UCSF is doing this, looking internally at policies and procedures, who's on the medical school application review committee, who's around the decision-making tables regarding a selection of residents, who's around the table for promotion and tenure. All of these things are critical, and that's what organizations can do. They can look inwardly at their own policies and procedures, and of course, we are doing that, have been doing that at the AMA, in addition to our most recent effort to launch a Center for Health Equity. You know, the AMA, many of you know, years ago, did not allow African American physicians to join the AMA. And in 2009, our then immediate past president, the late Dr. Ronald Davis, apologized. But of course, apologies are just the first step. It is what is the work after that. After that, we did have the Commission to End Health Disparities working with the NMA and the National Hispanic Medical Association. Lots of policy on this, but here is what I call AMA's continued journey. Not a perfect organization. I'm sure UCSF is not a perfect organization, but organizations as well as individuals need to be on our journey towards more equitable care. And of course, a physician should lead that. Again, another area where AMA is leading, and I'm so proud of the partnership with Essence and the NMA and the American Heart Association, the Association of Black Cardiologists, because we know that, again, Black women do not realize and did not realize that they are at increased risk for cardiovascular disease. So this was a great campaign we had to make sure that Black women were aware of this issue. I talked earlier about the need for diversity in the physician workforce. But not in the service of just a checkbox, right? These are the numbers. We need the numbers, but why? Again, we know that organizations are better. They perform better when they have a diverse workforce, when there are diverse groups, diversity of thought and opinion, and race and gender and ethnicity around decision-making tables. We know that we have a long way to go. AMA is certainly supporting pathway programs to get more people from communities of color interested in medicine. Clearly, there are many barriers, and so in partnership with the AMA Foundation, we raise dollars for our minority scholarships, along with the Minority Affairs section of the AMA. We have a Doctors Back to School program. Here you see a photo of the current Surgeon General, Dr. Jerome Adams. And this is certainly, if you can see it, you can believe it. That was one of the contributions that I hope that I have made over the course of my tenure, is to demonstrate that yes, you can become a physician. Yes, you can aspire to have the highest office in medicine. Yes, you can do these things. Now, when I talk to youngsters, I talk about that, but I think, again, back to us who lead large organizations, who lead systems, we have to make sure that the playing field, the opportunities are equitable. And everyone has that equitable opportunity to aspire to become a physician, to aspire to the presidency of the American Medical Association, to aspire to faculty at UCSF. And so this is the part that we have to play in large organizations and in systems. Something that we don't talk enough about at the AMA is our work through the courts on so many issues, physician gag laws, DACA issues, support for our international medical graduates. So all of these are areas where AMA is certainly in the arena to do what we can to increase the diversity of the physician workforce. Again, we've been very proud of our Accelerating Change in Medical Education initiative, where we, of course, as you know, gave 11 $1 million grants to medical schools to innovate how we train the next generation of physicians. And we started with undergraduate medical education. A couple of years ago, we gave grants for GME innovation, because we do want our medical students and residents of today to be prepared to be physicians in a new, transformed healthcare, transformed not only by COVID, but transformed by technology and innovation. There's so many things that impact our ability to care for our patients, and we want to make sure that we are training the next generation of physicians to be prepared for the transformed future regarding healthcare. AMA does have a lot of policy regarding integrating mental health. I talked to you earlier about the press announcement today in our work regarding integration. I just want to take a moment here. Very excited about the new California law. Parity, as you know, has been on the federal books for over a decade, but still not put into practice, not fully, I believe, has not fully met the promise of this law, and I bet you all can agree. And so thank you very much for your work in California on this law. Hopefully, it requires insurers, and, a lot of state insurance commissioners had not gone back to make sure that insurers were following the letter of the law regarding parity, and we certainly appreciate and applaud this work in California in relying on evidence-based treatment developed by physicians, right, not insurers. So thank you very much for your work on that. You heard me talk about, or you heard me introduce as being chair of the AMA's opioid task force. Clearly, we have work to do here. We have made progress, particularly around prescription opioids. A number of prescriptions have been falling, actually since 2012, but now we see a rise in overdoses and a rise in overdose deaths due to illicitly manufactured fentanyl analogs, and stimulants. Now we're seeing a lot of overdoses due to methamphetamine and cocaine, which is why, by the way, you will hear us at the AMA, and I think others, we of course were appropriately focused on opioids, but now it's really about overdoses in general, and it's really about working towards a system that makes sure there's treatment access for substance use disorder. Again, we have done our due diligence, we believe, as physicians in working toward decreasing the number of opioid prescriptions, registering for our PDMPs, treatment capacity increased some, but we know we still have a long ways to go, particularly when it comes to access to medication-assisted treatment for an opioid use disorder. Clearly, physicians are enhancing our education, and naloxone prescriptions are increasing, but again, we cannot stop there. The most recent recommendations of our opioid task force was regarding removing those barriers. You heard me talk about barriers early on, prior authorization, step therapy, all of those that are burdens for our patients getting medication-assisted treatment. Again, enforcing state and federal parity laws, and your law in California did just that. We also need to make sure we are removing barriers to pain care. Clearly, on paper, we can encourage physicians to recommend physical therapy or biofeedback or anything else, but if they are not covered by insurance companies in an equitable manner, our patients won't go. I have a car, I can drive, I have insurance, but we have to make sure that these alternatives to opioids are equitably available. We also have to make sure that we are increasing access to treatment for pregnant women and mothers. We have to support access to treatment within our criminal justice systems. However, you should not have to be arrested or be engaged or have an encounter with the criminal justice system in order to get the care that we need. And when talking about equity, let me say one thing about opioids. I always have to say that, when Black and brown communities in the 80s were dealing with heroin, which is an opioid use disorder, our country's response was incarceration. And now, of course, with prescription opioids, when most folks impacted, at least early on, were middle class and upper middle class white Americans, our response was treatment. Now, of course, I bet you everyone in this room agrees with me. We're glad to have people then change the conversation, but I think we cannot forget that our country's response, again, particularly when Black and brown communities were mostly impacted, that our response was incarceration. We really need to move from a crisis framework to a proactive, coordinated approach. Actually, I think this could certainly serve as a framework for any public health crisis, but certainly for those who have a substance use disorder. We have to certainly employ better surveillance strategies. And this, I'm a former public health director for 5 years, and we need to collect the data again so we know how to certainly target our interventions where and to what communities. And we have to make sure that our responses are culturally competent, culturally relevant, culturally sensitive as we address COVID, opioids, trauma, any crisis that we have in this country. So thank you for the opportunity to be with you today, and I look forward to questions, comments, suggestions, and a discussion.
Okay, thank you. Thank you very much, Dr. Harris. So, so this is a reminder, please do put the questions in the chat to me. We have some questions, Dr. Harris, that we can start with. And thank you very much for your presentation. It was wonderful.
My pleasure.
So one question we have is, how is the AMA thinking about navigating being a source of impartial information and good information, right, on COVID and everything else in such a politically charged environment where basic public health information is being so politicized?
Well, I would say that lane, if you will, is not new to us at the AMA. And this is, I think, that the House of Delegates, and for those of you who are not AMA, and it can be, traveling around the country, folks said, the AMA is such an opaque organization. So I realize it can be a little tricky, but to me, one of the jewels of our organization is how we make policy. Where we have, think about it for those of you who are not familiar, as the Congress of Medicine, where representatives from every state and every specialty come together, typically in person twice a year, to debate policy and vote on policy. Even at me, as a member of the Board of Trustees, 21 members, I no longer vote on policy. It's that House of Delegates, representatives from every state, every specialty, age group, the medical students, the residents, the senior physicians, the women, the minority affairs. Those are the folks who come together and debate policy, and it's based on science and the evidence, right, first of all, and then there is consensus. And so I think that that is one reason why our policy is so respected in DC, is because they know it's not just a tiny group that's coming together, with their own biases. I mean, here's open, fair-minded, passionate debate. And so the lane of being nonpartisan has been a lane that AMA has been for many years. Now, some people might, and so you could say we are partisan, we are partisan to our policy. And so now some people probably, didn't like in 1963, that the AMA did not support Social Security, right? But that decision is based on policy. Some people didn't like and saw as partisan our support for the Affordable Care Act. But I will say we made those decisions based on policy, right? And so that's a lane that we've always been in. And so it doesn't matter who comes up with a good idea. R, D, I, doesn't matter who comes up with a good idea. As long as that idea is consistent with AMA policy, we will support that. And so that's where we've been, and that's where we continue to be.
Great. And then here's another question. So you were mentioning about the challenges of reaching the African American, Latinx communities of color, especially now with COVID and vaccination trials coming up. And something that we're hearing is that communities really do not trust any of this process. You mentioned Tuskegee, I mean, that still is very much alive. Can the AMA be involved in that, or can we, how can we address that issue of just such deep mistrust?
We have, and we will continue to be. A couple of statements. I think this happened. Dr. Sue Bailey, who's our current president, pediatric allergist from Fort Worth, we sent a letter, and sometimes these letters, and this is fine because the AMA does not do this from, for publicity, but we sent a letter to the FDA saying, look, we need transparency on these issues. We need to see the data. That is our expectation, that this is a transparent process. And so and by the way, there are career folks at FDA that our folks at the AMA have been working with for decades, right? And so on a day-to-day basis. So we have those long-standing relationships with the career scientists, right? The non-political folks, the folks that are, keeping their head down, doing the work, following the science. And so we have relationships with across the agency at HHS, CDC, FDA. And so that's how we have and continue to work now. And we have, of course, made public statements about, again, the need for the science and the evidence and the need for transparency. And so we will continue to be there. And I can tell you that I'm going to expect that there is transparency in this process. But believe me, if there is not transparency in this process, if we think that it's politicized, we will call that out. I can guarantee that.
Thank you. Very important. Another question that we have. We all know that sponsorship is critical for academic success for women and underrepresented minorities, but operationalizing this is a challenge. Have you heard about any innovative programs or strategies across the country that are doing this well?
Here's where I think the work is required, because I think that, and my heart is broken, and I don't know, I have not known personally any of these folks, But when folks are saying, I'm leaving my academic position because they do not value me as a woman, or they do not value me as an African American or Latinx member. And so, and listen, I am not, I've not worked in that field. That's not been my path. But I say that I believe, and I have said to some, that we need to get the folks in the room that are doing something. I think we're early on in this journey. So and you all can tell me what you're doing. And I know you're doing a few things because I keep in touch with Jack Resnick. And I know some things are happening at UCSF. And I think that UCSF and maybe some other academic institutions. So to me, here's my fantasy. And I'm a psychiatrist, so by the way, I talked about fantasies in my inaugural address. I got a line. I said, psychiatrists can talk about fantasies, and we can talk about the cytochrome P450 system. So, but I believe things are going on there at UCSF. I've read about things going on at Yale. I've read about things going on at Columbia. So I think what we need to do is figure out a way to get the folks that are leading on this, and I think from what I've read and heard from Jack, in a room to begin to compile, right? Because I think everyone's so early and people are trying things and not everything, but let's get some folks in the room who are willing to lead on this, who are willing to put the resources. And let me say this, I say this unabashedly, because I think what's been happening before, these efforts have been off to the side. So there's been a task force, right, on increasing the number of women, increasing the number of communities of color. And the people that are on the task force have been women and communities of color, and they've had the responsibility, they've had to do all the work. So here's what, and you can let me know, and you can let me know, leadership has to come from the top, the very top, to say, this is a priority, and I'm going to put some money behind it. So I'm not going to just have the women and the Black and brown people working on this issue when they're also working on all the other issues that they need to do for promotion and tenure. So that's the first step, and I don't know who's doing that, and you guys can let me know. I know some things are going on at UCSF, but maybe and I don't know the structure of UCSF, but whomever the very top person is, and I guess, it is not my intention to call anybody out, but it is my opinion that leaders are going to have to do that. And I will say that one of the reasons I can sort of say that, and I'm officially representing the AMA, is because I know our CEO of the AMA, Jim Madera, has said, and of course the board, we have oversight, but he has said to everyone in the organization that Aletha, you heard me talk about Aletha Maybank and the Center for Health Equity, she's the quarterback, but it's not her responsibility. And what Jim did was made sure that in order to embed health equity into the DNA of the organization, everyone has accountability. So the dean then says all the chairs of all the departments have accountability. The dean has accountability. The board of trustees of UCSF have said this is a priority, and everyone who reports, of course, there's usually one person that reports to the board. I don't know the structure of UCSF, but this is in their metrics, and the person who is at the very top has their top levels. This is in our metrics. So it's about metrics, it's about accountability, and it's about dollars. And so, again, not trying to call anyone out. I know you guys are doing some good things there, but I think everyone's on their journey. So I'm not saying we should be there now, and it wouldn't be a bad thing if UCSF was not where I just said. But I think that's where we need to get folks in the room and say, here's what we need to do if we really want to improve.
Okay, wonderful. And I think
I'm sure I stepped on somebody's toes, but
no,
that
was perfect.
Not at all.
I see Matt shaking his head yes. So we have time for maybe like one more question. We'll see. But here's one. I'm so appreciative of Dr. Harris joining us, and I have much admiration for her pioneering work. Spoke about healthcare access and equity, and just now touched on the ACA. Despite some of the ACA successes, it fell far short of many of our hopes, and increasingly physicians are saying nothing short of a single-payer healthcare system will ensure all Americans have access to good healthcare. What would it take for the AMA to endorse Medicare for all?
So let me say a couple of things. As obviously the person who's asking the question knows that the AMA does not endorse and I'm gonna do this from the organizational standpoint, and then I'm gonna do this from the individual standpoint, just what I learned, because part of the story that you didn't hear, that some may not know, is when I was a resident finishing my fellowship, I believe, in forensic, because I did child and adolescent in forensic, I went down to the Georgia General Assembly. And anyway, that experience made me, it's a longer story, made me realize how important it is for physicians to get engaged and involved in advocacy. And that's sort of how I, worked at the APA, or worked my way up through leadership at the APA and the AMA. So I'll talk on the organizational and then my individual. So on the organizational standpoint, it is not our policy at the AMA to support a single payer. We support on building on the Affordable Care Act. And let me also talk about why I believe, the AMA believes, and I believe personally, that any long-lasting, sustainable solution is going to require bipartisan effort. In this country right now, we have two parties, and they're both at the state and local level. And one of the reasons, and I'm so glad the Affordable Care Act, and I have to say that I know that President Obama and his team wanted to work with the Republicans and wanted this to be somewhat of a bipartisan solution. But we know, and so since then the other party, and I would say that if another party had a solution, especially where we are right now, politics would intervene, and we would never get to where we need to be. So I just believe, the AMA believes, and I believe personally, that a bipartisan solution is the way to go. We believe that building on the success of the Affordable Care Act is the way to go. I also will say that Medicare for All, we should have in this country always a fair-minded debate about any proposal, and we will. Because at some point, someone will write the legislation for Medicare for All, and all of us will be able to dig deep through that, the 200 and some pages of the legislation, and I was on the Council on Legislation at the AMA, and I know our team, and we had 2-hour conference calls nightly going over every page, and I think, what was it, 200 or 300 pages? So I will say that the AMA does not respond to legislation unless it's written on paper. So Medicare for All, has not been put in legislation, but at some point it may be, and then we can, in this country, AMA included, have a fair-minded debate on that. And so that's, we will do that at that time. I will say this about single payer, and I want anyone who believes we should go to single payer, remember this, remember that framework that I showed in the beginning? I believe, this is my personal opinion, not AMA, we could have single payer tomorrow, and we still would not solve all that we need to solve around equity. So I do want people to be careful about, and this is my personal opinion, a panacea or a one-size-fits-all solution, because I believe when you have a one-size-fits-all solution, that doesn't allow for work around equity. Now, these are my personal opinions, but let's see. Let's see, have a fair-minded debate. And so I've shared my personal opinions and AMA's policy and stance.
Wonderful.
But let's not pretend, this is my personal opinion, let's not, people tell you when you're searching for a house, don't fall in love with a house. Let's not fall in love with something. Let's see it on paper in legislation, and let's not expect it to solve all of the problems. It would solve some problems, but it wouldn't solve all of the problems.
Thank you, Dr. Harris, so much. Thank you, Dr. Fortuna, for moderating the Q&A. Dr. Harris, a wonderful talk. We're so grateful you decided to do this, or agreed to do this, and we really hope that when the Earth starts spinning on its axis again, that we can get you out, hopefully for more than a little bit of time, to come and really spend some time, learn more about UCSF. It would be so valuable for our faculty, our staff, our trainees to really get an opportunity to hear more. Wonderful. Thank you so much. Thank you, everyone.
Thank you.
We're back on track with our academic program. Until the next time, take care, everybody.
Thank you so much, Dr. Harris.
Thank you.
Bye. My pleasure.